Hey everyone, welcome back to another episode of Shock Doc Medical. I'm Dr. Rod, and today we're diving deep into a topic that's super important for both patients and doctors alike: skin cancers and their precursors, specifically solar, actinic keratosis, and Bowen disease. Now, have you ever wondered how chronic sun damage can turn into something that might even lead to skin cancer? Or how a seemingly harmless scaly patch on your skin could actually be a red flag? Stick around, because by the end of this episode, you'll be armed with all the information you need to recognize, evaluate, and treat these conditions. Let's kick things off by talking about the big picture. The sun is amazing, right? It gives us warmth, light, and vitamin D. But too much sun exposure, especially over the years, can cause serious damage to your skin. One of the ways this damage manifests is through solar or actinic keratosis, AK. These are pre-malignant lesions where the basal cell layer of the epidermis becomes dysplastic. What does that mean? In simple terms, your skin cells start to change in a way that indicates chronic sun damage, and they can be a marker for the risk of developing skin cancer. Now, here's a surprising fact. About 20% of solar keratoses regress spontaneously. However, the progression of an individual lesion to squamous cell carcinoma, SCC, is pretty uncommon, less than 1 in 1,000 per year. But, and this is a big but, when you have areas of coalescing solar keratoses on sun-damaged skin, what we call an actinic field change, the risk of progression to SCC goes way up, especially if the patient is immunosuppressed. So folks, this is one area where early detection and proper treatment can really make a difference. All right, let's get into the nitty-gritty. What should you be on the lookout for if you or your patients might be dealing with solar keratosis? First off, these lesions tend to be asymptomatic or only slightly itchy. They're usually brownish-red, discrete, scaly, or keratotic patches that show up on sun-exposed areas. Think the bald scalp, the face, the helix of the ear, and even the dorsum of the hands and forearms. Some of these lesions might be raised and even warty, which we refer to as hypertrophic solar keratosis. Now, if you start noticing any pain, induration, inflammation, or ulceration, that could be a sign that the lesion is progressing to SCC. And don't forget, the presence of chronic sun damage might also be accompanied by other skin tumors, like basal cell carcinoma, BCC, or malignant melanoma. So it's absolutely critical to keep an eye on these areas. So, what should you do if you spot these lesions? First, always advise your patients to monitor their skin closely for any signs of skin cancer and to protect their skin from further sun exposure. Now, treatment for solar keratosis is generally only necessary if the lesions are troublesome or if you're dealing with that confluent actinic field change. For isolated lesions, lesion-directed treatment, LDT, might be sufficient. But if you have a larger area, over 1 square centimeter with subclinical dysplasia, that's when you want to lean towards field treatment, FT. Sometimes both approaches can be used together, depending on the situation and the patient's risk factors. Here's a rundown of your treatment options with some specifics on medications and doses. 1. 5-fluorouracil, 5-FU, cream. This is your first-line treatment for both field treatment and lesion-directed therapy. In a large multicenter RCT, 5-FU outperformed imiquimod, ingenol mebutate, and mal-PDT. There are various regimens out there. Standard regimen: apply once daily, QD, or twice daily, BID, for 2 to 4 weeks. Alternative regimen: some practitioners use it 3 times a week for 8 to 12 weeks. Often, 5-FU is combined with a topical corticosteroid, TCS, antibiotic combination to reduce local skin reactions like redness, crusting, and discomfort. It's also available in combination with salicylic acid for hypertrophic AK, and even shorter courses, like 4 days, have been described when used with calcipotriol ointment. Specific formulations include Fudex 5% cream, 40 grams, 2% solution, 10, 25 milliliters, Fluoroplex 1% cream, 30 grams, Carac 0.5% cream, 30 grams. 2. Cryotherapy, a quick and popular option for lesion-directed treatment. Cryotherapy has shown response rates ranging from 39% to 76% in systematic reviews. However, do warn patients about the risk of blistering, scarring, and pigment changes. 3. Imiquimod cream, used for field treatment. Typically, it's applied 3 times a week at night for 4 weeks. Local skin reactions are common, so patient counseling is important. 4. Surgical options. For For hypertrophic AKs or lesions where other treatments have failed, surgical removal via curettage and cautery or shave excision is often employed. This is also a great option when you need to confirm the diagnosis and rule out invasive SCC. 5. Ingenol mebutate gel. This is used for field treatment, applied once daily for 2 to 3 days. However, note that prescribing of ingenol mebutate has been suspended in Europe and Canada due to concerns over a potential increased risk of SCC. This is still under investigation. 6. Diclofenac hyaluronic acid gel, another field treatment option, applied twice daily for 60 to 90 days. It tends to cause milder local skin reactions compared to 5-FU and imiquimod, but its efficacy is generally lower. 7. Tirbanibulin ointment, the most recently approved therapy for non-hypertrophic AK. It's used once daily for 5 days. There haven't been head-to-head trials yet, but it's an exciting new option. 8. Photodynamic therapy, PDT. Both conventional and daylight PDT using aminolevulinate, ALA, or methyl ALA can be used for field treatment. Meta-analyses suggest that PDT is superior to cryotherapy, although one RCT showed that treatment success for conventional PDT was lower than that for 5-FU or imiquimod. For PDT, you might use Levulan Kerastic topical solution 20% with blue light, blue U, or Amylase 78 mg spray nanoemulsion gel 10% with red light, BF Roto LED. 9. Laser resurfacing. This includes ablative or non-ablative fractional lasers used for field treatment. They can be combined with other topical therapies to enhance outcomes. 10. Chemical peels. In a small study, a combination of Gessner's peel plus 35% TCA peel reduced visible AKs by 75%, which is comparable to 5-FU. This is another field treatment option. 11. Systemic chemoprevention. For patients at high risk of cutaneous SCC, systemic retinoids and nicotinamide can be used to reduce the overall burden of AKs. Wow, that was a lot of information. But here's the bottom line. Understanding and recognizing the signs of solar keratosis and Bowen disease is crucial. Whether you're a patient keeping an eye on your skin or a doctor managing these conditions, early detection and tailored treatment can make a world of difference. Remember to monitor skin for asymptomatic or mildly itchy, brownish-red scaly patches, especially on sun-exposed areas like the face, scalp, ears, hands, and forearms. Look out for any signs of progression like pain, induration, or ulceration. Use appropriate treatments based on the extent and severity of the lesions, from topical agents like 5-FU, imiquimod, and diclofenac, to cryotherapy, surgical options, and even newer therapies like tirbanibulin. Always emphasize sun protection to your patients. I hope this deep dive gives you a robust toolkit to tackle these conditions. If you're a fellow doctor, share your experiences in the comments. Let's build a community where we learn from each other. And for our patients, if you notice any suspicious lesions, don't hesitate to get them checked out by a professional. That's all for today's episode of Shock Doc Medical. If you enjoyed this deep dive into the complexities of actinic keratosis and Bowen disease, be sure to hit that like button, subscribe, and join the conversation in the comments. Let me know your thoughts, your questions, or even your personal stories about dealing with sun damage and skin lesions. And stay tuned. Next week, we'll be uncovering another groundbreaking discovery that might just change everything in the world of dermatology. Until then, keep questioning, stay informed, and remember, your skin is your story. Take good care of it. This is Dr. Rod, signing off from Shock Doc Medical. See you next time.